Hello, everybody. My name is Tally Foster, and I'm an occupational therapist. I've been working with children with various physical and neurological conditions for about 25 years. And I've had the honor of working with one child with HIVEP2 disorder for most of his life, including prior to his diagnosis. It's been an amazing learning opportunity for me, and it continues to this day. So I'm honored to speak with you all today on the topic of identifying and meeting sensory needs. So as I understand that most of you are family members of amazing children with HIVEP2, I hope to provide you with some information that will help you in some way. This education session has been designed to provide a better understanding of sensory regulation and behavioral responses in children with complex and rare diseases in general. I believe most of you are familiar with addressing behaviors, both positive and negative, from a behavioral perspective, and this is great. As you've learned behavioral strategies, one of the techniques that they ask you to consider is the antecedent of a behavior. What comes first, right? One of the areas of that to consider is often listed as a perhaps sensory sensitivity. This is important to consider. And I want to take this opportunity to expand your understanding of sensory processing in general by explaining the reasons behind both sensory avoidance behaviors and seeking behaviors. So I will discuss managing and preventing unwanted behaviors by identifying, promoting optimal sensory regulation. That's the goal we're going to go for. I plan to help you identify the sensory systems to start, to understand their impact on function and cognition, understand general principles of sensory regulation, compare both behavioral and sensory regulation approaches, and then we will consider some sensory regulation strategies that may help. So let's start here. Very basic, right? We have 7 sensory systems that bring us information about everything around us. This is how we function. This is how we learn. This is how we interpret our world. These include, many we're familiar with, visual or seeing, auditory, that's our hearing, olfactory is smelling, gustatory is taste, tactile is just a fancy word for touch, but many different types of touch. Vestibular is our sense of movement, and the receptors for that are located within the inner ears. And proprioception, which is our unconscious awareness of where our body and parts are in space. So these receptors are located in the structures that connect our joints, such as ligaments and tendons. The system is responsible for you knowing your position in space right now. It's the information that allows you to maintain your position in a chair without sliding down or falling out. It's how you control reaching for an object in front of you and how much force you may use to pick it up. So always playing a role. If we look at this pyramid of the central nervous system, you'll see that it's a hierarchy, right? We see that the sensory systems are at the base. They're the foundation of this pyramid. It's what everything begins with. And at the very top, you will see that it includes academic learning, daily living activities, and behavior. So those are the highest things on the pyramid. And there are many other components included in the levels between them. And they include sensory motor and perceptual motor development areas. So all of these middle areas are part of sensory processing. And they're also dependent on a regulated sensory state for the development of them to occur. So it's a bit cyclical in nature, right? So think about how all the sensory systems learn to work together. If one area is providing too much information, it may drown out information from another area and provide an incomplete picture. If one area is not registering enough information, then it won't contribute to the picture at all. So deciphering through all of that information is what's necessary for sensory motor development to occur. And this includes areas, as you see here, such as motor planning, postural security, body scheme, awareness and use of two sides of the body, the ability to screen and filter input that's coming in. The sensory motor skills are then necessary for perceptual motor development to occur. And that includes things such as eye-hand coordination, control of eye movements, especially in combination with body movement, appropriate postural adjustments, processing of auditory input for language skills, visual spatial perception, and attention skills. And that's a big one. So to better understand sensory processing and regulation in general, I would like to present you with an illustration. So everybody has a different size glass to fill. Some people have a very tall glass, while other people have a very short glass to fill. If we are going to fill our glass with different information from the environment, the goal is to get it to fill up to the top with all of the different types of input until it registers that it's full. If we have the right amount of information, we could be in a calm, alert state, ready for learning. If we have too much information, we can be excited and even extremely excited. Sometimes too much information can cause a shutdown response, which can be the result of too little information. Sensory processing includes input, which is when we register information, and then it moves into processing, which is where information is organized, interpreted, and stored. After processing, we produce output that is a response to the information. In the case of a short glass, it will fill quickly. It does not need much information. It quickly overflows and you can get a very quick response. In the case of a tall glass, it will fill slowly, need a lot more information. It will be underfilled and you will see a slow or perhaps even no response. Now consider that we may have different size glasses for each type of sensory input. Okay, so this may vary for all the different types of input that those 7 systems we've talked about. As well as having perhaps an overall, what I would call a master glass to fill, right? So this can mean that each sensory input can require more or less to register each type. And then the combination of these inputs also contribute to an overall master glass, which could be taller or shorter, to get to that appropriately regulated state. This master glass can also be weak. It may not remain intact for long. It could spill out, break apart, and require frequent replacement. So that's kind of an indication of how long we can remain regulated. We all actively engage in sensory regulation, and we're constantly either seeking or avoiding, adjusting or altering inputs around us everywhere to achieve whatever the desired state is we're going for. So the desired state sometimes may be a quiet, alert state where active learning occurs, right? Calm and relaxed when we desire to rest or fall asleep. Or even an excited state, right? When you want to participate in very active tasks like sports, recreation, something very engaging that requires a lot of energy. Think about the things that you do to achieve those states, to maintain those states, or to shift those states, right? The options are endless. We all do it different ways, and they vary between everybody, right? So however they vary, we all have the same 7 sensory systems in common. So that's what's the same, right? You can also think of times when you've had perhaps difficulty matching your state with the demand. Some of you may think coffee here, right? That's a coping mechanism. Others think about different types of input. Could be music, could be movement, could be touch, could be taste, could be smell. How do these things affect you? How do you remain in charge of your regulation state? This is not something we think much about as we've learned it over a long period of time. When kids fall out of the range of normal for their ability to regulate, they basically have no idea, first, what the optimal level of arousal even is for that situation. They don't know how to achieve that state. They don't know how to remain in that state. And they don't know what to do if it's not working, right? So this is where all of the outside support comes in. That support is us. It's you. It's everyone that's involved in your child's daily activities. We are going to discuss what we call the optimal learning zone as a goal and how to recognize some of your child's needs. We're also going to discuss when to address your child's responses from a behavioral or perhaps a sensory perspective. And sometimes it's a combination of both, right? The goal is always to help your child get into that optimal learning zone. That means that the child has received enough sensory information, but not too much, to be alert. We consider kids with short glasses, as we described, hypersensitive to sensory input. Remember, this means they don't need much to fill their glass. We consider a child with a tall glass hyposensitive to sensory input. That means they need a lot more. Each child may vary in either direction with each type of sensory input, as we said, and it's important to have the support, perhaps, of an occupational therapist to determine a full sensory profile of your child. Because what I'm explaining here is a little bit complex to do on your own. Doing a sensory profile is based all on information that you can answer about your own child and what you already observe, but it's guidance and a good way to organize and label each area of sensory input, and it allows perhaps for a better plan going forward. The first step would be to recognize how the child responds to different types of input. And we will look at examples of those soon. We must learn what types of sensory input are stimulating for your child and which types are calming. The next step will be to observe how long this state lasts and when more adjustments or inputs are needed. And that could be more input or an adjustment away from input, right? Modifying something to make it less, either way. Now, think about in every activity, such as eating. Think about all the sensory input that goes along with eating. There's taste, there's smell, there's sound of chewing, people talking, the texture, temperature, feel and resistance of the food in the mouth or on the hands, the joint input of body position while you're eating, the weight of food, a cup or a utensil in the hand or in the mouth. There's the visual image of food, color, texture, shape, contrast of the plate, temperature, the table, the surroundings, including other people, the environment around them, the lighting, right? Fancy restaurants go to great efforts to set up environments that influence many of those factors, with hopes that you will appreciate that. and return. We must carefully consider these factors to determine which types of input need to be added to the scenario or taken away. All right. So behavior, as many parents are familiar with a behavioral approach, behavior is defined as the way in which an animal or a person acts in response to a particular situation or a stimulus, right? This means that behaviors are always a response to something. And that's important here. So that something always includes some form of sensory information. Every behavior of a child is intended to serve a purpose for them. Although we do not always and often do not understand what that might be, professionals in applied behavioral analysis, so ABA, focus on the behaviors, and they use learning principles to bring about behavior change. Of course, the focus that we want to talk about here is on unwanted or negative behaviors that may cause harm to the child or others, or is just not socially acceptable. Many behaviors adversely affect those around a child. They can interfere with learning, performance of daily tasks, and of course, even safety, right? So making changes in these behaviors is very important and it's necessary. From a sensory processing perspective, we would consider more of the root of the behavior, right? Back to that antecedent and the sensory part. We find it's important to discover more of the why behind why the behavior developed and to determine what sensory need is being met by that behavior. Because again, it's always for a reason. So kids that have a tall glass may have tall glasses, maybe trying to fill it up. Kids with short glasses, maybe trying to avoid filling it up or just reacting to it being overfull. The reaction is still a behavior that's aimed at some form of coping, perhaps by blocking out other stimuli or serving as a release, right? A meltdown, a tantrum can serve this purpose. It's still done for a reason. So I like to say that the golden rule of a sensory approach is to never take something away without giving something back. So think about it for a minute. What do you do if you feel deprived of something that you think you need? Will you probably seek it out in some other way, right? Will you try to find a way to meet that need? Are there positive ways to do that, negative ways to do that, to find a replacement? What ultimately do you want to select? I assume you would want to preferably select a positive replacement, right? We don't want to select something that will do harm or take us down another negative path. So it's important to guide our children to replace a behavior that is sensory-based, that is needed for them to regulate, with a suitable option, right? It has to meet the same need to be successful. So it's best to have guidance. Ultimately, it's best if you have some guidance in options that might be available. That's the tricky part, coming up with ideas. We want to make sure that those options are meeting the same underlying need. There's another part of sensory analysis. This is another part of sensory analysis that can be best guided by an occupational therapist. Just another resource in that process. The first step of achieving a regulated sensory state is understanding your child's sensory profile, as we just discussed earlier. The next step becomes observing their responses in various environments and circumstances. And that's a lot of different circumstances, a lot of different environments we place our children into. with a lot of variables. So the work should start with the activity or setting or circumstance where you notice your child is most regulated. Start in the most positive spot, okay, if you're thinking through this process. Remember, what you're looking for is what looks like an optimal state for learning. They're alert, they're engaged, they're responsive, they're emotionally positive. That's the ideal scenario, or the most positive they get for these states for your child. Notice the things that appear to be contributing to their state, to this positive state. These factors could be the environment around your child, the activity itself, the sensory inputs, the demands being placed on them, whatever behaviors they are using to help. You want to take in all that information. Start small. Select a few things and try to replicate that or add to them in a different scenario. So try to carry some of those things you think are helpful over to a different activity or over to a different environment, but start small. You can't do everything at once, or you won't know what's working and what's not. Then you continue to observe the effects, always observing the effects, right? Think of other options that may provide the same types of input. That's how you build on it, right? What else might help in different scenarios? Consider all the input types. Remember all 7 senses and how they are being affected by them. It is well worth the effort on your part to, I call it, set the stage, right? Optimize a learning state with your child first, just to achieve even a few minutes of active learning or skill development. This will build over time. That state will last longer. They will develop the ability to build a skill and build upon that. Celebrate those small accomplishments, however small. Understand that the next goal is to achieve and remain in a regulated state for longer periods of time, right? Building a stronger glass. We must also consider that children may respond to too much or too little stimuli in various ways. So a child may avoid a type of input because they are sensitive, right? They have that short glass, it gets really full, really fast. They don't like that response. They may choose to avoid it. That's a coping mechanism. How they behave to avoid it is what we see. Could be a lot of different ways. They may not know how to avoid that information at all. And then they may become overwhelmed. So a child that doesn't know how to be an avoider, but they're still sensitive, have a short glass, it gets full, it overflows. Now they're just overwhelmed. That might look very different, right? They may not know how to get out of that scenario. They may not know how to prevent that scenario. They don't know to avoid. Therefore, they're maybe melting down or having a reaction or a response in any possible way. A child may be a seeker of input because they might have that tall glass, right? They have a high threshold to meet and they're trying to get there on their own, right? So they're finding ways to seek input in any of the possible sensory areas. Now, they might do that in an effective way or perhaps a maladaptive way, right? Back to, is it harmful? Is it socially acceptable? Is it harming others or themselves, right? Is it problematic? So that's maladaptive. So we need to come up with what's an effective way for them to do it. But we still need to understand that they're seeking that for a reason. It's serving a need. So conversely, they may not know to seek input, even if they have a tall glass and need a lot of information. That looks different, right? So now you will see a response that looks like understimulation It might resemble being unengaged in an activity, tuned out or aloof, just not as aware of what's going on. Certainly not an optimal state of learning, right? So I want to go through some examples of some sensory processing difficulties that may or may not be similar to your child, but I just wanted to give some examples and kind of talk through them a little bit and how they relate to sensory processing. So one area I'm going to mention is hypotonia. Now, you're probably wondering why I'm mentioning this, because it's commonly considered, right? It's a physical problem. So as I'm sure most of you know, hypotonia is defined as an abnormally low level of muscle tone. And tone is the resting state for activation of our muscles, different than strength. As this is commonly understood as a physical limitation, right? I would like you to consider this problem area from a sensory perspective as well. Since physical control of a muscle and sensory processing all come from the brain, we can agree that this is neurologically controlled. So the interesting thing about muscle tone is that it can be adversely affected by poor sensory processing as well. And this is not something we often think of. It happens when there is poor awareness of that proprioceptive input, perhaps a tall glass in this area. If there's a poor awareness of where your body and your body parts are in space, then there's little connection to activating muscle tone for movement or even just holding a posture, right? This poor activation can lead to a child falling off a chair, sliding down out of a chair, sitting or standing with poor posture, poor development of those protective patterns of movement, like catching yourself when you tip over or fall, and many more things. While this can create a cycle that ultimately can lead to muscle weakness, right? It's not all caused by muscle weakness. And there are children with low tone that still have strength in their muscles to activate. They just have times where they do not turn it on, right? So this is an example of a physical area of development that requires a focus on sensory processing, such as increasing overall arousal level and demand of the body through activation of other sensory systems in order to improve that muscle tone activation. Okay, so again, you can think of examples in yourself where we may be influenced, our tone may be influenced by sensory input. That's what bass in music does. It makes people activate actual muscle tone. There are emotional responses where we activate, right? There are things that cause us to relax our muscle tone. When do we sit up straight? When do we slouch? How that's tone. That's the state your muscles are resting in. And that is influenced by multiple sensory factors. Okay. So keep that in mind, the difference between, say, tone and strength. Like I said, having low tone over a long period of time can then create decreased muscle strength because you're not activating very often. So it then feeds into itself, right? And another area we can discuss can be, an example would be tactile seeking behaviors. That might be grabbing items, throwing, tearing, squeezing, breaking things. These can be the result, for example, of overstimulation, either visually of objects or the environment, too many sounds, right? Other sensory systems may be overfilling and creating a response. These responses will be more prevalent when that underlying regulation is not achieved. So reducing the external stimuli first, then providing an opportunity to perform a regulating type of activity, which we'll talk about in a minute, before interacting with those items might help. Sensitivity to visual stimulation, like individuals moving around, a video, can cause overstimulation as well for some. Again, avoiding too much of this stimulation when the response is present is a good idea, as well as training a child in providing them with regulating types of activities to prepare for that regulation prior to exposure may help. Slowly introducing amounts of visual and sound stimulation is also a good approach. Sometimes children make loud noises themselves just to drown out other noises that might be overwhelming to them, and that can be misread. Introducing calming sounds and music may help regulation, might reduce attention to those other sounds. We can give them good opportunities to drown those other sounds out without them having to create certain ones on their own if they're not desirable for the rest of us. All of these are examples of stimulation affecting overall attention as well. And really, the problem with attention is actually can be a hyperattention and an oversensitivity to other stimuli that causes difficulty attending to a particular task, right? Seeking behaviors can look like constant movement, can be oral seeking, kicking, hitting. These may be attempts to seek regulation input as well, although not in appropriate ways. Exploring other ways to guide the child in obtaining that input through safe and appropriate means may actually increase their overall regulation and then their attention to the task. So, for example, sitting on a seat that moves can sometimes increase awareness of the body and space by increasing that demand on having to maintain posture. Securing a child's feet to a foot plate or against a resistive band, or while they're performing a seated task, such as eating or some other seated fine motor task. It might improve their focus and attention to the task because they're being provided with an opportunity to increase proprioceptive input in their legs and their feet, but without the distraction of a bunch of extraneous movements, right? So you're giving them confines within their space so they can get the input they're looking for more effectively, but not in a distracting manner for themselves. And then that can all increase learning. So providing another example, providing an opportunity to use an appropriate chewing tool, could be food, any kind of safe chewing item, may also improve regulation for some children by providing that opportunity for both tactile and proprioceptive input through the mouth, through the jaw, which is a nice means for many to achieve that. There is a big market out there for chewing gum, and it's not because it's a great source of food. Many of us seek that input, use that input, help us regulate, helps us concentrate. Not everybody, not everyone buys gum, but a lot of people do. So there's definitely things we already do. Now apply that concept to your child. So there are endless strategy options. This is the area that could go on forever and be very individualized. There are endless strategy options available to use to achieve and then maintain regulation. So it will be different for each child. However, there are some generalizations we can make, and that's what I'm going to give you here are the generalizations on some ideas so you have a starting point. And it's based on how the sensory systems integrate in the brain. For example, the most primitive systems that develop neurologically are the proprioceptive, vestibular, and tactile systems. They're stimulated in utero through the mother's movement and the space around them. These sensory systems are found to be more calming and alerting, and can help provide a grounding force for other sensory systems that might be more sensitive, either under or more underreactive, right? So we rely on these more primitive systems because they're often more effective, more developed. They've learned to use them for a longer period of time in their life. Motion can be alerting and organizing, but consider the type, because depending on the type, you start involving other systems, right? Linear motions, like one direction, such as swinging, can be organizing, but spinning can be much more stimulating, right? Now you're triggering more of the vestibular system, more of the visual system, and it's has a stimulating effect. Pressure and touch can be calming and settling. Also depends on the type and the child. It can be used as a transition strategy or a sign to get the body ready. That's often how we know what's going to happen. We use our sense of touch and pressure as we transition ourselves. Heavy work provides movement, vestibular input, and deep pressure, which is proprioceptive input, for alerting and for calming. So those are good choices, and there are many creative ways to produce heavy work. It's just a term categorizing activities that stimulate those two systems. Sucking, chewing, and breathing can be organizing for improving an alert state and to help with focus. It's important to consider taste, textures, smells, sounds with food as well, depending on your child's other areas of sensitivity, perhaps. And it's also very important to remember when retreat is necessary. So this includes the opposite of providing input. It's reducing sensory overload or other inputs, such as visual, auditory, areas that are more likely to be overstimulated. Implementing routine and planning actually allows your child to then build on cognitive support strategies that they can develop through familiarity, predictability, and what we call pre-warnings. So they kind of get a heads up and start learning what to expect, what's coming next, how they might prepare themselves for that. They develop the combination of some cognitive thoughts and strategies with those expected sensory inputs. So it is important that we consider routine, and we also consider planning, which allows us to change routine but still give them time to know it's coming. As they may learn strategies of support, reducing the number of unpredictable variables will ultimately increase their success. So we can't always do that, but the most we can reduce the unpredictable parts, the more success we'll be seeing, or at least understand that so that we can understand why they're having a harder time at certain times, because perhaps there are more unpredictable variables. So this is also helpful for the caregivers, right? To improve your own consistency with guiding sensory strategies. Routine helps, planning helps. We all benefit from routines. So it's important that you select and modify strategies that work for you all, whoever your network is, the entire family, the entire caregiver support team. by building strategies that fit into your routines, your everyday tasks, rather than adding everything, adding too many tasks and daily requirements. The goal isn't to give you a longer list of things to do. It's just to alter the things you are doing, build it into your routine when possible so that it just happens and it fits. Think of the things that do work successfully in your own life because they're built into your routine. So consider organization of tools or items, support systems in your own daily routine when you select these strategies. There are numerous websites, blogs, books, etc., things I don't even know what they're called. They're available with tons of ideas for different sensory systems. So I encourage everyone to use those resources, but consider the principles we've talked about here so that you understand it's still about individualizing and trying strategies for your child, and that just because someone says do A, B, C, D, and E and it works for their child does not mean those things will work for yours. But get the ideas from these networks, get some creative ideas about items and techniques and strategies, and what works for someone else might be, you might pull one item out of their list, right? There are weighted items, compressive wear items, fidgets, oral chewies, multitude of swings, too many tactile objects to mention. The great news is that many of these therapy items have made their way into mainstream stores, which I also find interesting. I find it very confirming too, because it just proves the point that we all are sensory beings and we all are finding value in these products, and they're not just for those that fall out of the norms. They actually help everybody. So this is great news for, say, price point, because now things are more available, more affordable, and that's excellent. This doesn't mean that everyone will like every single item for themselves, right? So keep that in mind. It's still a process of trial and error. It always is. And go slow and try one thing at a time. There is no right or wrong tool or strategy, just the goal that you find what works for your child, what works for your family, and most importantly, that it's something safe for everyone. Although you may benefit significantly from skilled guidance, which could be with a therapist, in improving your child's sensory regulation, even with that support, the whole process requires active collaboration with that child's caregivers, with you, to ensure everyone's needs can be met effectively. Remember, everyone's regulation matters. So this is an example of a simplified daily routine with some identification of the effect of the activity or the accommodation. So this is just to give you a visual. It can be expanded in detail into what we call a sensory diet. Just as we feed ourselves with food in a diet, this is feeding the brain, right? The body and the brain, the sensory system. That diet can be a full daily routine with lots of detail. It can remain just a general outline. You can have a list of strategies to draw on for certain circumstances. But it may be helpful to kind of put some things down as you go and to learn what works, what doesn't, and keep kind of a running list for yourself and for those that interact with your child. My advice, though, start small. Add one thing at a time. Observe your child's response. Do what works for you and for them. Do not give up quickly. Be easy on yourself. This isn't easy to do. Remember that the child's needs change over time and also in different circumstances. So don't be surprised when something worked on Monday and it didn't work on Wednesday. There may have been other variables, other circumstances, so don't give up easy. Maybe try again. but also understand that you might need different strategies for different circumstances. Children are affected by everything, by medications, by illnesses, by sleep patterns, altered sleep, growth spurts, different stages of development, and also the state of those around them. We affect them all the time. We all affect each other. So children with sensory processing that's outside of the range of normal will always have those influences, right? They may always have taller or shorter glasses than what is typical. But focused intervention and different strategies can help adjust those thresholds, perhaps even help modify or adjust the height of those glasses a little bit. And the goal of regulation is management, not a fix. It's managing. That is what we do. We all manage our sensory regulation every day. We're teaching our children to manage it as well. And they still need outside help to do that, right? Just like they do at different stages for many other things. And that is the goal for them, for you, for everyone. And we want to manage that in order to ultimately optimize their learning ability, optimize their function as often as possible. Even if it's a moment, how many of those moments can we get? Build, build, build. Celebrate the successes and the amazing qualities of your child. Use those strengths. Focus on their strengths and what they bring to those around them. Thank you all so much for your time. I've enjoyed being able to share this information with you, and I look forward to any questions that you may have.
Thank you so much. My name is Siddharth Srivastava. I'm one of the neurologists at Boston Children's Hospital. And today I'm going to talk about a whirlwind tour of different types of seizures, epilepsy, and EEGs as it relates to HIVEP2 disorder. I've structured this talk in a question and answer format. So this is based on a lot of questions I've received over the years as they relate to seizures, and not just HIVEP2 disorder, but also other complex neurodevelopmental syndromes. So let's get started. Here is a quick outline of my talk. In the first part of my talk, I'll talk about seizures and epilepsy. In the second part of my talk, I'll talk about EEGs. So first, let's talk about seizures and epilepsy. I get this question a lot. What is the prevalence of seizures in HIVEP2 disorder? So the prevalence of epilepsy or seizures in HIVEP2 disorder is not entirely clear. So from the Simons Searchlight data, about 25% have a history of at least one seizure, and about 17% have a current diagnosis of epilepsy. And I'll explain the difference between those terms in a second. And from previously published data, we know that about 20% of individuals have reported prior history of seizures. Just for context, the prevalence of epilepsy in the general population is only about 1% or so. So this is indeed an elevated risk for seizures in HIVEP2 disorder. So what exactly is the difference between seizures and epilepsy? So let's start with some basic definitions. A seizure is just a symptom of brain disturbance. It's caused by synchronized abnormal electrical activity, abnormal electrical discharges that are occurring in the brain. There are two different ways to define epilepsy then. So epilepsy is defined as having two or more unprovoked seizures separated by at least 24 hours apart that have occurred in one's lifetime. Epilepsy can also be defined as having one unprovoked seizure along with the strong risk of having recurrent breakthrough seizures in the future. Unprovoked seizure means a seizure not in the setting of infection, and not in the setting of electrolyte disturbances, not in the setting of other factors that may have triggered the seizure. The term seizure disorder is the same thing as epilepsy. What are the different parts to a seizure? So is it just the seizure itself? Is there something that happens before, something that happens afterwards? So keep in mind that epilepsy affects each individual differently. One person may have a set of symptoms and progression that can be different from what someone else may experience. So with that said, there are 4 different parts to a seizure. Before the seizure, there can be a prodrome, which is a change in mood or behavior hours or days sometimes before a seizure occurs. Examples of these subjective feelings include confusion, anxiety, irritability, headache, tremor, anger, and other mood disturbances. The ictal phase describes the time between the start of the seizure and the end of the seizure. And aura can be the earliest sign of seizure activity. So not everybody experiences aura, but symptoms can include the following. You can have sensory changes such as strange smells, feeling or sensing bitter, acidic taste in your mouth, vision changes, ringing, buzzing. There can be motor symptoms such as jerking of one side of the face, arm, or leg, inability to move or speak. There can be autonomic symptoms such as dilated pupils, flushing of the skin. There can be psychiatric symptoms such as déjà vu or jamais vu or out-of-body sensations. The ictal phase can also differ from one person to another. So this can include a wide range of possible symptoms, and we'll go through them in the following slides. The recovery period after the seizure is known as the post-ictal phase. This can last minutes, hours, or sometimes longer before someone returns back to their baseline. Symptoms during this period can include arm and leg weakness, body soreness, confusion, drowsiness, malaise, headaches, nausea, and so on. Families often wonder, what are the different seizure types? We classify seizures based on 3 concepts: where the seizures start in the brain. Is it one side or is it both sides? We classify seizures based on a person's level of awareness during the seizure. Is the person aware, responsive, or not during the seizure? And we classify seizures based on whether motor symptoms occur or not. So based on these concepts, we can classify seizures into focal onset seizures, generalized onset seizures, and unknown onset seizures. I'll review focal onset seizures and generalized onset seizures in a bit more detail. Focal onset seizures start in one part of the brain. When a person is awake and aware during a seizure, it's called a focal aware seizure. This used to be called simple partial seizure in previous nomenclature. When a person is confused or their awareness is impacted in some way during a focal seizure, it's called a focal impaired awareness seizure. This used to be called a complex partial seizure previously. During focal onset seizures, motor symptoms may include jerking of the face, arms, or legs, clonic movements, tensing of muscle groups, i.e. tonic, the muscles becoming limp, i.e. atonic, brief muscle twitching, i.e. myoclonus, epileptic spasms, which are events in which the body flexes and extends repeatedly in clusters. There may also be repeated automatic movements like repetitive or rhythmic clapping of the hands, lip smacking, chewing. During focal onset seizures, there may also be non-motor symptoms such as changes in sensation, emotions, changes in thinking or cognition, autonomic disturbances such as GI sensations, waves of heat or cold, goosebumps, heart racing, and so on, or lack of movement called behavioral arrest. Generalized onset seizures affect both sides of the brain at the same time. For generalized onset seizures, motor symptoms can include rhythmic jerking of the arms and legs, so clonic movements, muscles becoming weak or limp, atonic, muscles becoming tense or rigid, tonic, brief muscle twitching, myoclonus, epileptic spasms in which the body flexes and extends it repeatedly, as we discussed previously for the focal seizures. Non-motor symptoms in the context of generalized onset seizures are usually called absence seizures, which can look a lot like staring spells. These can be typical or atypical absence seizures. Atypical seizures tend to begin a little bit more slowly and last longer, up to a few minutes or so. Absence seizures can also have brief twitches, myoclonus, that can affect a specific part of the body or just the eyelids. Keep in mind that in many cases of staring spells, these can actually be focal onset seizures and are not necessarily absence seizures. In other words, not every staring spell is an absence seizure. In terms of seizure types reported in HIVEP2 disorder, focal onset seizures have been reported, including focal seizures with impaired awareness. Generalized seizures have also been reported in the context of HIVEP2 disorder, and these include generalized tonic-clonic seizures as well as myoclonic seizures. What is the range of epilepsy severity in HIVEP2 disorder? So there is a spectrum of epilepsy severity ranging from uncomplicated epilepsy, in which the seizures are well controlled with medication, and there can also be a severe side of the spectrum in which there is refractory epilepsy. In refractory epilepsy, seizures are persistent despite adequate trials of at least 2 anti-seizure medications that have been well tolerated and that are appropriate to the person's seizure type. Seizure frequency in HIVEP2 disorder can range from infrequent, so occurring once every few years, to frequent, happening multiple times a day. A particularly severe epilepsy syndrome called Lennox-Gastaut syndrome, which is characterized by multiple seizure types and a specific EEG pattern. This has been reported in the context of HIVEP2 disorder. So this question comes up a lot. Do seizures cause brain damage? So generally speaking, seizures do not cause permanent brain injury. Most seizures are self-limited, on the order of a minute or shorter, and they do not cause brain damage. On the other hand, convulsive seizures that are prolonged, so lasting longer than 5 minutes, that's an emergency. So this needs treatment immediately because there can be a risk for injury to the brain if this persistent, ongoing seizure longer than 5 minutes is left untreated. Diastat is a medicine. That's one example of a rescue medicine that we give to parents in case there is a seizure longer than 5 minutes or so. This is not a daily medication to prevent seizures. This is not a medication to increase one's threshold for having a seizure, but I'll talk about medications that do help protect against seizures in the next coming slides. So what are the treatment options for epilepsy? So there's a wide variety of treatment options for epilepsy. Anti-seizure medications are often the first line for treatment. Note that these medications treat the symptoms. They don't treat the underlying condition. Surgical procedures and implantable devices are options if the seizures are refractory to treatment with medications. And then finally, there are dietary interventions like the ketogenic diet that can be used for some individuals in whom medications have failed to control the seizures. So let's start by talking about anti-seizure medications. So there are several considerations that help us as neurologists decide on a choice of medications. We consider mechanism of action. Is the medication good for focal seizures versus generalized seizures? We look at the side effect profile of the medication and whether the benefit may exceed the potential for side effects. Many anti-seizure medications require regular lab monitoring, which is another consideration if the child has difficulty with blood draws. We look at whether the medication will have interactions with other medications or even certain foods. Some medications may have, some anti-seizure medications may have an additional benefit, say, for example, on mood. And then finally, cost and availability also comes to mind as we decide on medications. This is a table that goes through certain examples of seizure medications. It's not meant to be comprehensive, but just to give you some ideas of what is currently in use. So this question comes up. So tell me more about the side effects of anti-seizure medications. So this is a big topic when we're talking about choice of anti-seizure medications. Side effects can be unpredictable in that what works for one person without side effects may not work for another person and may be associated with side effects. Some side effects can be dose dependent, meaning that they can vary depending on the person's height or weight. Examples of these dose dependent side effects include drowsiness, dizziness, irritability, unsteadiness, blurry vision. Some side effects are not dose dependent. So this includes weight gain, weight loss, memory and thinking problems, osteopenia or osteoporosis. And some side effects represent a drug allergy. So side effects that, examples of such side effects include having a skin rash that's severe, or anaphylaxis, which is an emergency, a severe drug reaction. Is treatment with anti-seizure medication lifelong? So this question comes up a lot as well. So the answer to this question is not necessarily. So if you've started an anti-seizure medication and you're now seizure-free for 2 years, then at that point we would consider repeating the EEG, and I'll talk about the EEG in the next section. If the EEG is normal, then we could certainly consider weaning off the anti-seizure medication. I like to counsel families that if we do this, there is a chance the seizures could return. Many families wonder, so what's the chance that my child's seizures will respond to anti-seizure medication? So generally speaking, 2/3 of patients with new onset seizures will be seizure-free with anti-seizure medications. And then, which basically means that 1/3 of patients will not be seizure-free despite multiple anti-seizure medication trials. So this is the category of drug-resistant epilepsy or refractory epilepsy, which, as I mentioned before, is defined by not having adequate seizure control in spite of doing at least 2 or more trials of medications that are well tolerated, that are appropriately chosen, that are appropriately used regimens. The good news is that in the case of refractory epilepsy, there are other options besides medications, and these other options include vagal nerve stimulation, which I'll talk about, and dietary therapies as well. The vagal nerve stimulator is a device that's approved by the FDA as an add-on therapy for individuals 4 years or older. So it's approved to treat focal seizures that are not responding to seizure medication. The therapy basically consists of a device that's implanted under the skin in the chest area. The device is attached to a wire that's also placed under the skin. The wire is attached or wound around a nerve called the vagus nerve that resides in the neck. The device delivers pulses or stimulation at regular intervals. If a person is aware when a seizure happens, they can swipe a magnet over the generator in the left chest area that sends an extra burst of stimulation to the brain. Side effects of this device include hoarseness, coughing, shortness of breath. What about other options like dietary treatments for epilepsy that are difficult to control? So sometimes dietary therapies are a consideration in these individuals with refractory epilepsy. Options include the ketogenic diet, the modified Atkins diet, low glycemic index diet. Out of these 3 options, the ketogenic diet is probably the most restrictive in what you can eat and what you cannot eat. The modified Atkins and low glycemic index diet are less restrictive and easier to tolerate for some people, however. The ketogenic diet is a special high-fat, low-carbohydrate diet. It's stricter than the other two diets I mentioned. The classic ketogenic diet consists of, basically provides or restricts you to having 3 to 4 grams of fat for every 1 gram of carbohydrate and protein. So you're basically restricting the amount of carbohydrates. The diet, however, requires careful supervision with a team skilled in the ketogenic diet. And the reason for this is because there can be side effects such as constipation, low blood sugar, reflux, kidney stones, high cholesterol levels, and other side effects. So what about specific anti-seizure medications used in HIVEP2 disorder? A number of anti-seizure medications have been used for HIVEP2 disorder. So these include Keppra, Depakote, Lamictal, even CBD. However, there's not enough data to suggest that one type of medication or anti-seizure medication may be more effective than another for HIVEP2 disorder. So let's switch gears now and talk about EEG, or electroencephalography. Up until this point, I haven't really mentioned EEGs, but EEG is, of course, a huge part of the workup of epilepsy and seizures. So let's spend some time talking about it. First off, so what even is an EEG? So EEG stands for electroencephalogram, and EEG is a brainwave test used to indirectly measure electrical activity that is going on in the brain. It's part of the evaluation for a child who has epilepsy or is suspected of having epilepsy. During an EEG, a tech sticks electrodes onto pre-designated areas or places in the scalp, on the scalp. This test is non-invasive. In other words, the electrodes are not inserted deeply into the skin. Rather, they're attached by a sticky glue to the head. You don't have to lie still, but during an EEG, we often like to capture brainwave activity while you are awake, but also while you are sleeping. What exactly is an EEG used for? So there are a lot of reasons why we use an EEG, but some of the big ones are as follows. So first of all, kids will often do funny movements or spells, and sometimes it's hard to tell if that's a seizure or not just by looking at that activity or that spell. The gold standard way of confirming if a spell is a seizure or not is by looking at the EEG pattern during the spell. If the EEG changes in a way that's consistent with the seizure, that confirms that the spell is a seizure. If the EEG does not change in a way that's consistent with the seizure, that suggests that the spell may not actually be a seizure. A second big reason why an EEG is useful is for helping diagnose epilepsy. Remember, epilepsy is diagnosed if you have 2 or more unprovoked definite seizures. However, in many cases, after the first unprovoked seizure, we'll get an EEG. And if the EEG shows that the background brainwave activity is significantly abnormal in a way that suggests a predisposition for having seizures, then I think there's enough to say that there is a strong chance of having recurrent seizures. In other words, even after one unprovoked seizure, if the EEG is highly abnormal in a way that suggests a likelihood of having future seizures, that would be enough to diagnose the person with epilepsy. A third reason why we get EEGs is to better characterize seizures themselves. Are the seizures focal? Are they generalized? Are they coming from one particular part of the brain? These are questions that the EEG can help answer. For many families, an EEG seems like a huge black box. So let me break down this question of what does an EEG recording look like? So the EEG recording looks like basically just squiggles. So each line represents a recording from one of the electrodes. And remember, there are many electrodes that are attached on the scalp. The x-axis is time and the y-axis is amplitude in terms of microvolts. The recording can be done over 30 minutes, sometimes hours, sometimes days. So this screenshot represents maybe, I think, 10 seconds or so of a recording. So this is just a really brief snapshot of a total EEG, which can be 30 minutes or hours or longer. So what are the possible interpretations of an EEG? So there are a couple of different possible interpretations of an EEG. It can be normal or it can be abnormal. If it's normal, we like to state whether it's normal while the patient is awake or asleep or both. What makes an EEG abnormal? First off, there can be abnormalities in the background. So the background is determined by looking at the frequency and rhythm of brain waves and seeing if they are appropriate for the patient's age or not. So sometimes you can have slowing, meaning that the EEG waves are slower than what you would expect for the patient's age and state, meaning resting versus awake. The slowing can be continuous, meaning all the time, or it can come and go. The slowing can be generalized, meaning present everywhere, or it can be focal, meaning present in just certain parts of the brain. In the example below, on the right, you see a normal EEG, and on the left, you see slowing, which means that the frequency of the brain waves is slower than expected. In other words, there's just fewer numbers of squiggles per time. You can also see epileptiform abnormalities. So this includes seizures that are captured on EEG. You can tell from the EEG if the seizures are focal or generalized, and you can also tell if they're electrographic, meaning you see them on the EEG, but there may not be associated clinical changes. This differs from electroclinical, where you can see them on the EEG, you can see the seizures on the EEG, and there are also associated clinical changes. I've shown an example of a seizure on EEG. It looks a little bit like an EKG. The squiggles are lined up or synchronized. So in EEG terms, that's a bad thing. You want activity to be irregular and chaotic. You can also see other types of epileptiform abnormalities. So this includes things like sharp waves or slow or spike waves. So basically these refer to different shapes or waveforms that are seen on the EEG that are abnormal. You can characterize whether these abnormal waveforms are rare, occasional, or frequent. You can also characterize whether these abnormal waveforms are focal or generalized. I've included an example highlighting some of the spiky waveforms that are abnormal. Waveforms like this do not mean that you are having a seizure per se, but they do suggest an increased threshold for having seizures in the future, or in other words, an increased predisposition for having seizures in the future. Is there a specific EEG pattern that's seen in HIVEP2 disorder? So in general, right now, there is not a specific EEG pattern that we see in HIVEP2 disorder, at least not yet, not that we know of yet. Types of abnormalities on EEG that have been reported in association with HIVEP2 disorder include sharp waves, spike wave discharges, as well as slowing or slow activity. So how do we translate these EEG abnormalities back to the person? So the question really is about clinical correlation. In other words, what does an abnormal EEG mean clinically? What does it say about what could be going on clinically? So if there are seizures that are seen on the EEG, that is diagnostic of epilepsy. That's either generalized or focal. If there are generalized spikes or epileptiform activity seen, then we say that the EEG is consistent with epilepsy of, if there's generalized spikes seen, then we say that EEG is consistent with epilepsy of generalized onset. But it's not necessarily diagnostic of epilepsy, because you could certainly have generalized spikes on EEG without having clinical seizures. So similarly, if there are focal spikes seen on the EEG, then we say the EEG could be consistent with epilepsy of focal onset. But once again, that's not necessarily diagnostic of epilepsy, because you could certainly have focal spikes on EEG without having clinical seizures. If there's generalized or focal slowing, then we say there's global cerebral dysfunction or focal cerebral dysfunction in whatever areas are impacted. Some people wonder about the term encephalopathy that they see on some EEG reports. So the EEG is a test of brain function. So encephalopathy means that there is diffuse brain dysfunction. So this shouldn't necessarily be a surprising finding, given that we already know that within the context of HIVEP2 disorder. We know that HIVEP2 disorder is associated with autism and intellectual disability and a vast array of neurodevelopmental dysfunction. In other words, there's already evidence that we appreciate in terms of brain dysfunction with respect to HIVEP2 disorder. The most common EEG pattern associated with diffuse encephalopathy is generalized slowing. And, diffuse or generalized abnormal patterns are by definition indicative of diffuse brain dysfunction. So does a normal EEG rule out epilepsy? If the EEG is normal, it makes the diagnosis of epilepsy less likely, but it does not necessarily rule out completely a clinical diagnosis of epilepsy. Seizures are paroxysmal events. They come, they go. They are not happening all the time, so the changes on EEG won't show up all the time either. If a person keeps on having a spell and there's a strong suspicion that the events may be seizures, and the events are not captured on a regular routine EEG, then we may need to repeat the EEG with a longer recording. So maybe capturing at brainwave activity for a couple hours, or in some cases, 72 hours, a couple of days, to really try to capture the event on EEG. So should we get an EEG just because we have a diagnosis of HIVEP2 disorder? So generally speaking, I would suggest that you should get an EEG if there are concerns for clinical seizures. Otherwise, if you get an EEG just because it may be abnormal and you're left with wondering, well, what exactly are we to do about this abnormality? In other words, it may not necessarily change clinical management and it may lead to unnecessary worry. Another scenario to consider in EEG in the absence of clinical events is if there's developmental regression. So if there's loss of language, this scenario can be associated with ongoing seizure activity, particularly during sleep. And this may not necessarily be associated with discrete clinical events. So this is one scenario where we would get an EEG, even if there isn't clinical events. So the scenario of developmental regression, especially language regression. So with that said, I wanted to say thank you to everybody. I know this was quite a whirlwind tour. This is a big and complicated subject, but I hope this has been helpful. And lastly, just to acknowledge a variety of people. So thank you to the Simons Foundation. Thank you to my mentor, Dr. Ann Fedori, some of whose slides I used in this talk. Thank you to Hope for HIVEP2 and all of the families who have been involved. I learned so much from the families, and I'm always appreciative of everything that I can learn from them in our interactions together. Thank you.